So the tracheostomy tube is an effective interface between patient and the ventilator, and it allows the patient to be easily connected and disconnected to the ventilator as the patient needs. One of the big complications is the buildup of secretions in the intercannula that might cut off the airway. So that's one of the things that if a patient has a trach, one of the things that is most worried about, and that is why the trach has to be cleaned so often, because their body is going to be really producing a lot of secretions at and around this tracheostomy tube. And the outer cannula is only pulled out by the doctors, and only when it is determined that the patient can go without the tracheostomy. So that patient is able to breathe without the trach. It's only the inner cannula that gets pulled out and cleaned so often to ensure that that airway isn't getting clogged with mucus. Because as you can imagine, doesn't take a lot of mucus to seal off the end of one of these. And the term that is used is a mucus plug, and that is basically exactly what it sounds like, a big piece of mucus that gets stuck in here. And oftentimes, if you are the one removing the inner cannula for cleaning, you want to be positioned so that you're not in the path of any mucus that is going to be blown out of the outer cannula when you pull this out. And also you want to have your glasses on, because if you're sitting there right in front, then you're going to get a blast of mucus. All right, so let's get a little bit more into detail with all the different configurations and common features of tracheostomy tubes. Let's start with the cuff. Some trachs have a little balloon on them, and that is known as the cuff. So if this is placed in the patient, you can see that the cuff is deflated. So in this particular scenario, I have not sealed off the patient's airway. So when they inspire, they can be pulling air through the trach, or they might be pulling air down around the cuff through the trachea down into the lungs. The cuff is hooked to a little thing that is called the balloon. So we don't refer to the cuff as the balloon. This is the balloon. And you inflate the cuff. You inflate the cuff with a syringe. Let me put a little bit more air into it. Okay, so now you can see that cuff is very much inflated, as is the balloon. So this thing, the balloon, is always hanging out. And that is how you know if the patient's cuff is inflated or deflated. And if the cuff is inflated, you know that patient is only breathing through the tracheostomy tube. He or she cannot breathe past the cuff that is sealing their airway. So looking at this model, you can see that with the cuff deflated, that patient is going to breathe past the tracheostomy tube through their natural airway. But with the inflation of the cuff, that is going to seal this off up here from the lower airway. So no air is going to be able to get from below the cuff up into through the vocal folds into the pharynx, oral cavity, nasal cavity. It's all going to be entering and leaving through the tracheostomy tube. So the cuff is important for ventilator patients because if this patient is on a ventilator, you want the cuff to be inflated so that the air that's being pushed into the tracheostomy tube by the ventilator doesn't simply go into the trachea and then circle out back through the mouth. You don't want the air to be able to leak from down here up here if that patient is on a ventilator. So that cuff seals the airway and keeps the air, the ventilator air, being pushed in from leaking out so that it appropriately inflates the patient's lungs. So to reinforce what I just said, if you have a ventilator-dependent patient and their cuff is deflated, so you could look at the balloon, you could feel it, you could see that the cuff is deflated. In this scenario, that ventilator air that's being pushed in is just going to cycle out the bottom of the tracheostomy tube, and it's not going to continue in to expand the thorax because that would take too much pressure. It's going to follow the path of least resistance. Path of least resistance, which would be around the cuff and back out the mouth. So we just have the ventilator-dependent patient sitting there with air being pushed in here and coming out their mouth, and that would not be a good situation for their survival.
When a tracheostomy tube is introduced, the functions of the airway can be dramatically changed. Some tracheostomy tubes have a cuff to assure that all air moves in and out through the tracheostomy tube during mechanical ventilation. Proper cuff inflation should be maintained at all times. Overinflation of the cuff can cause many complications, including necrosis and trauma to the delicate tracheal tissues, as well as esophageal impingement with possible swallowing difficulty and reflux. Proper cuff inflation is best achieved by measuring the pressure in the cuff with a manometer. Even with proper cuff inflation, complications arise when airflow bypasses the upper airway, mouth, and nose. Normal sensation and airway pressures are lost. As a result, tracheostomized patients have diminished or absent functions of the aerodigestive tract. Absence of airflow through the vocal folds leaves patients without the ability to speak, causing significant frustration, anxiety, and distress. For children, losing the ability to use their voice during the critical early years of development can lead to significant speech and language delays. Patients with tracheostomies also have reduced senses of smell and taste, which can lead to poor appetite and compromise nutritional status, sometimes requiring supplemental feeding through a nasogastric or PEG tube. In addition, many of these patients have difficulty swallowing and aspirate. The cuffed tracheostomy tube may anchor the larynx, interfering with laryngeal elevation, epiglottis inversion, and airway protection. Because air escapes through the tracheostomy tube when the vocal folds close, positive subglottic pressures cannot be generated during swallowing. Reduced sensation in the larynx and pharynx leads to pooling of material in the airway, and also reduces the protective cough reflex, which is necessary to clear the larynx and trachea when penetration and aspiration occur. When patients are unable to breathe through their nose, they are unable to filter, warm, and humidify the air. This has an impact on the quantity and quality of their secretions. Because patients cannot sense these secretions and generate the necessary pressures to cough, secretions accumulate in the airways, requiring suctioning by a caregiver and increased risk of trauma and infections. An open tracheostomy tube does not allow a patient to generate positive end expiratory pressure or physiologic PEEP. Without PEEP, the alveoli, which are the sacs of air in the lungs through which gases are exchanged, can collapse, causing atelectasis. Significant atelectasis results in decreased ventilation and oxygenation.
So a couple important points. As you saw in that video, it is common for secretions and aspirated materials to collect on top of the cuff. All right, this is why as the SLP, you're probably never going to be deflating the cuff without a nurse or a doctor around, because there's a pretty good chance that if you deflate the cuff, that is going to allow any secretions or aspirated materials that have built up on top of the cuff to fall directly into the airway, creating a respiratory crisis for the patient. And that is something, as the speech therapist, you do not want to be responsible for. Also, if the patient is predisposed to dysphagia in the first place, then oftentimes the doctors will put the cuff in place, perhaps not for the purposes of being able to hook the patient to a ventilator, but just to keep aspirated material and secretions from falling down into the lungs. But that can be problematic in itself, because there's no real guarantee that the secretions and the aspirated materials are not going to be able to leak around the cuff and get below. And also the presence of the cuff, as we already said, could irritate the inside of the trachea that much more and create problems for the patient. So if a patient has a cuff, an inflated cuff, they are not able to cough because no air is able to pass through the vocal folds. They are not able to phonate because no air is able to pass through the vocal folds. So they're not able to talk. These individuals will oftentimes be communicating via writing while they're in the hospital. And we're going to come back to this, but one of the big problems with all trachs is the negative impact they have on the swallow by anchoring the larynx in place. So if you swallow, you can feel your larynx and therefore your trachea lift up under your skin and drop back down. But if you have a trach placed, then that is holding your trachea to this part of your neck, to that skin. And so when the patient goes to swallow, that larynx is trying to lift, but it's anchored to this part of your neck. And without appropriate hyolaryngeal excursion, then you're going to have a compromised airway. The airway is possibly going to be more open during the swallow due to the decreased laryngeal elevation, possibly putting you at more higher risk for aspiration and penetration.